Yeah, thank you to GGC and Professor Natarajan for giving me this opportunity. So I would be also talking on the similar lines as Dr. Vinay Gupta, and as a clinician pointing out the instances where genetic diagnosis and a genetic uh, implications have helped me in managing my patients. When I, joined work as a pediatric ophthalmologist, I was not aware that that genetic disorder is so prevalent among my patients. In fact, every other child I was seeing had some connection with a genetic mechanism that was happening, either direct Mendelian disorder or some predisposition to a genetic condition or genetic situation. So when I went back and read about it, I saw that inherited eye disorders actually constitute more than 50% of legal blindness in children, and thus they have a huge economic and social impact. If you look at the eye, and these are only the monogenic disorders that I have, monogenic or polygenic disorders which I have mentioned, but not the ones where there are multifactorial disorders which also have a genetic connection. So it could be also complex because of chromosomal involvement, then direct DNA deletions, duplications, or even single nucleotide changes, plus and minus systemic associations. So how does a clinician try to apply this to their own practice? So this talk essentially gives us clinical examples of how application of genetics helped in diagnosis, prevention, or management of the disease, how it helped us understand the segregation of the disease in the family or establish a genotype-phenotype correlation. Also some clinical examples of limitations of genetic testing and counseling, some avenues for research in genetics for clinicians, and the last part probably I'll skip because it's already been covered by previous two speakers. So I begin with this 26-year-old male who presented with a history of sudden loss, painless, gradual progressive, very slowly progressive, simultaneous bilateral vision loss at 18 years of age. When he came to me, he was 26 years and he was still finding answers as what is happening to him. His old records documented bilateral optic neuritis, for which he had received intravenous methylprednisolone at that time. His current vision was 1/60 in both the eyes, and fundus showed bilateral optic atrophy. So what was odd in this case? I could have easily dismissed this patient as a sequelae of bilateral severe optic neuritis, maybe a NMO positive patient. So what was odd? But he didn't typically fit into the typical optic neuritis gender, being male. Also, the slow progression even after treatment was not fitting into optic neuritis, and MRI being normal, although not unknown, but it's still a little odd. So can I do something more? That was the question. So only a simple thing like a family history, which was not taken before in this patient, revealed that there are two other siblings from the maternal side who have been similarly diagnosed as bilateral optic atrophy at a young age, optic neuritis at a young age, and which is very odd for optic neuritis. So definitely this was a hereditary optic atrophy, most commonly LH1 because it's more common, and also maybe X-linked optic atrophy. But what should I do? Should I examine the parents? Unfortunately, the other family members and parents were not present for examination, but we did genetic testing of the mitochondrial gene and did found a gene in the variation in the MTND4 gene, which signifies Leber's hereditary optic neuropathy. So why is it important to make this diagnosis for this particular patient? And taking this example, a genetic diagnosis helps us in prognostication, which would be very different for optic neuritis as compared to hereditary optic atrophies. The management are quite different. Of course, IVMP was really not required in this patient. Had it been diagnosed at the early time, he could have benefited from Idebenone prophylaxis to prevent involvement of the other eye, or maybe help in a little bit recovery also. And genetic counseling is definitely not applicable for an optic neuritis, but it's very relevant in an LH1, and especially the sister of and the other female siblings of all the affected ones need to be counseled for their children being at risk for this disorder. Family history and examination of parents is extremely important for all suspected genetic diseases. It can sometimes directly clinch a diagnosis. For example, a tapetoretinal sheen in female carriers of X-linked RP, posterior vise sutures in female carriers of Nance-Horan syndrome, and anterior sutures, sutural cataracts in carriers of cerebrotendinous xanthomatosis. So these can directly clinch a diagnosis and even not require a genetic testing. Coming to the second case, where the diagnosis was not very difficult. This was a 2-year-old male, observed lack of eye contact at 4 months of age, normal development milestones. There was a hyperopia with nystagmus, ocular digital sign was positive, and a normal fundus. So this was typical Leber's congenital amaurosis. But here, the mother was pregnant at this time, and they wanted to know the recurrence risk and also what is the chance of this baby having the disease, and wanted to prevent it. And he was clearly born of a consanguineous marriage. So we told them there's a 25% chance, but they wanted to test it. So at this point, genetic testing helped us to plan a prenatal diagnosis, and a similar mutation was found in the ongoing pregnancy, and the parents, plan to terminate the pregnancy. So here it lies in our, armamentarium. It's our duty to advise them for these kind of prevention strategies which are present. It is very difficult to live with one child with a debilitating and a blinding disorder, and imagine having 2 or 3 kids with the same disorder. So it's a duty to advise them to have this kind of a counseling done, and options of prenatal and pre-implantation genetics all should be given to the parents. And these are some examples of how phenotype-genotype correlation helps, especially in the retinal dystrophies. I'll not go into the details of this. Coming on to the next case, which was a 5-year-old male. This one also had a very similar kind of presentation, and here we suspected that this was a severe early onset rod cone dystrophy, and because of that he also had a hearing issue, probably an Usher syndrome. Here the diagnosis was just made because the parents wanted a genetic testing was done because they wanted a definitive answer. But lo and behold, what we found that he actually had NCL, which is neuronal ceroid lipofuscinosis, and what we were thinking that he's probably having a walking difficulty because of his vision problems actually turned out to be a CNS involvement of this patient, and unfortunately this patient succumbed a couple of months after the diagnosis, in fact. So again, it's the onus of the ophthalmologist sometimes to pick up these disorders and refer them so that these kind of things may not happen if the condition allows. So sometimes you just don't have any other things but these red flags, like any intellectual disabilities, any other neurological issues, some congenital anomalies, dysmorphic features, history of immunodeficiencies, history of recurrent pregnancy loss in the mother, and anything odd should clinch us towards some other problem going on in the child and not dismiss them just as an ocular disease. Coming to one more case where this 11-month-old baby girl, she presented to us with bilaterally small eyes since birth with nystagmus and very poor vision, born of non-consanguineous marriage, the first child of the parents, uneventful pregnancy, no developmental delay. So looking at the external picture, looked very typical of a microcornea with a coloboma, this almond-shaped cornea and pupils, but a deeper look revealed that she also had a PHPV kind of a thing where elongated ciliary process was there. The lens appeared to be inferiorly dislocated and also dislocated posteriorly into the vitreous cavity. I had never seen something like this. I also did a B scan, and here there was a PFV stalk, or the persistent fetal vasculature, there along with the coloboma. So this was a combination of microcornea, posterior megalolenticonus, a persistent fetal vasculature, and chororetinal coloboma. And I had seen this for the first time when I googled it. It fitted into this MPPC syndrome, and very few cases have been described worldwide, and it has been postulated that somehow that incomplete closure of the embryonic fissure also leads to the non-absorption of the PFV stalk and leads to a combination of this. But it's so rare that there has to be something going on wrong, some other gene interactions having and affecting both these mechanisms or both these developmental processes. But unfortunately, till now, no genetic cause had been identified. Now, these parents were wanting again a diagnosis because they were planning next pregnancy and they wanted if we could help them. So we did a clinical exam sequencing, did not come out significant for this particular disease, but came out for Smith-Lemli-Epuit syndrome, which the child didn't fit into. So we also did a micro-air and extended micro-air. Again, no testing, but nothing came positive. The mother became pregnant in this process, but we did advise him for a good level 2 ultrasound to at least detect globe abnormalities. So the learning points is that genetic tool may not always provide answers. The disease phenotype offered determines the yield of the tests, and choosing an appropriate testing tool is important. And extremely rare disorders may require research level testing, like in this patient probably a whole genome sequencing would be the next step. It lies in a, again a duty to report some of these abnormal features or some unusual features that we see in our patients, like in this patient who presented with a diagnosis of Holt-Oram syndrome referred by a cardiologist having microphthalmos cataract, but this axon-field rigor like anterior segment dysgenesis didn't fit in the picture, and genetic testing revealed a B-core gene mutation, and this anterior segment dysgenesis had not been reported previously in B-core gene as well. And while we were publishing this case, only one other case got published, so there is a two cases reported to have this anterior segment dysgenesis. So we as clinicians can actually expand the phenotypic, expands of the phenotypic variety or the phenotypic knowledge of these disorders and have better clinico-genetic correlations. This patient had aniridia, again came to us for prenatal counseling, came out to be a PAX6 mutation, but because of incomplete evidence had a VUS. So segregation analysis in the family confirmed that this is probably a pathogenic mutation, and again reporting this case can help us convert these VUS into likely pathogenic or pathogenic in this. And the last one is, as Dr. Wiggs also mentioned in a talk, is that by collaborations with scientists and basic researchers, we can actually kind of expand these and have a meaningful collaboration, meaningful studies, like with my collaboration with Dr. Ansel Watinek from Cincinnati and Dr. Brooks and Dr. Vanita from Amritsar. We are trying to study the genetic constitution and the differences between 200 patients in India versus the USA, and we'll be doing gene dephenotyping, exome sequencing and whole genome sequencing, and also in evaluating zebrafish MAC models, especially are targeting the retinoic acid pathway genes, because we believe that probably there are some connection between the maternal vitamin A deficiencies and the retinoic acid pathway genes, which is kind of making the patients in our population have more severe variety of microphthalmos, anophthalmos and coloboma. So I'll skip this treatment options and in the end to just summarize that supportive care is very much important for these patients. If at all we can't do anything, at least get them a good genetic counseling, link them to various support groups, help them with whatever vision rehabilitation is possible or cosmetic rehabilitation sometimes, and we really need to collaborate with pediatricians, geneticists, genetic counselors, and definitely not send out the patient saying that if there's no cure, it does not mean no hope. So thank you everyone for your patient listening.
Thank you.